I guess I'm just scared that because of the over exuberance in a very short period of time, healthcare operators, especially given typical healthcare orientation, will write it off as all hype when the reality is maybe 99% of it is hype, but you still have to find the needle in the haystack that actually does add value, and the value that it will add faster than I think a lot of us will realize is going to be game changing in terms of what it can do for kind of the healthcare ecosystem.
Welcome to Healthcare Ops Wave. It's not only an acronym for how, but also healthcare operations and waves are actually very similar. Both are steady, run in cycles, and have the odd storm in between. I'm Frederik Mueller. I'm the co-founder and CEO of Third Way Health, and we'll bring you the stories that shed an inside look on the humans behind healthcare operations.
All right. Well, welcome to the Healthcare Ops Wave. I am very excited to be with our next guest, Brandon Sim. Brandon, welcome, and thank you for taking the time.
Of course. Thanks so much, Frederik. Really excited to be here. This is actually the first time in a while I've been doing a podcast, honestly. So I'm excited to do it and looking forward to our conversation today.
I am as well. No, this is great. And I'm very excited, Brandon, because really the point of the show is to shed some light into the humans behind healthcare operations. And I feel like a lot of where I see your name pop up is really around the leadership of an organization. But there's a whole operational side that I feel like it will be really interesting to highlight here. Maybe to get us started, can you give us a quick intro to yourself and also how you ended up in healthcare to begin with?
Yeah, happy to just do a quick intro. So my name is Brian. I'm currently the CEO and president at Astrana Health. We are a healthcare organization that tries to empower providers and allow them to succeed in value-based arrangements. We serve around 1 million Americans today in value-based arrangements across multiple states, primarily with roots in California, part of the West Coast, and we serve patients across all patient types, and whether they're Medicare Advantage, Medicare Fee-for-Service, Managed Medicaid, commercial. You really want to empower providers across their entire panel, something we're very passionate about. Our organization's been around for a long time, since the 90s, and we've slowly and steadily grown until then with the same focus of trying to empower community providers and give them the tools that they need. Myself, I've been at the company for around 5 years. I think probably have a bit of an untraditional background for healthcare. My passion growing up was to try to figure out a way to advance, even if by a little bit, the frontier of what humans can do as a whole. And so for me, I thought that my dream growing up was to do that via academia, honestly.
Oh, really?
I studied physics and math in my undergrad. I wanted to get a PhD. I did a master's program in computer science and machine learning. I published a couple papers. I thought that was kind of how I would make my mark, so to speak. And there were a couple things that changed my mind about that and drew me to healthcare. One was that, the biggest one, frankly, was that I don't think I was smart enough to be really impactful in academia. I didn't think I could really contribute at the highest levels in creating the next field theory model or the latest AI model or anything like that. And if I were, it would take a long time to do so. I think the other thing was in academia, it was easy to get jaded around the type of impact that you're actually having. You can publish papers, you can build new models, you can contribute to knowledge, but that knowledge doesn't necessarily make its way to the hands of the average American, to average person. So I think in moving to healthcare, I found an opportunity in my mind to advance a field that could really use some advancing, where the bar to make real meaningful contributions to people's lives was frankly a little lower than it is in other fields. And to see that the work that you're doing is really tangible and you can see the impact of that on, like what I said, over 1 million Americans today, anytime we do anything, make any kind of improvement. So that's really fulfilling to me and kind of a bit of how I started into healthcare.
I love that. And I feel like something that no one that has interacted with you will say is that you're not smart to do anything, but I think it speaks to also how you have grown into the type of leader that you are. Maybe just to round out your introduction, can you share a little bit about your evolution? I believe you started as a project manager and rose through the ranks. So what did that sort of teach you about healthcare operations? Because, project management is about as tangible as it can get.
Yeah, no, thanks for asking. The project manager position was the title they gave me because they didn't know what to call me. at the time when I started. This was back in 2019 when I had first left a more quant research type job in finance. And part of the reason they didn't know what to call me is because they had never hired a software engineer before. I was the first kind of software engineer hired by the company, even though my title wasn't that to begin with. The company didn't believe in hiring software engineers, frankly, at the time. And so it was easier to be a project manager. I came in at the minimum wage possible to be an exempt employee. It was in the mid $50,000 range at the time. And my job was to try to understand some of the processes that were going on and try to build software to make those processes more efficient. In many ways, some of the same type of change management that you and your team have gone through working with our org as well. Back in 2019, the company was a very different place. We had a couple hundred employees. We've added a zero to that number in 2024. We're now at around 2,000 employees. We've more than tripled revenue and profitability since that time and increased the amount of members that we serve and providers that we serve in our network. Over the first 20 years of our life, we operated very much in a mom and pop fashion, focused on clinical interventions, but not so focused on, we may talk about this a little later, not so focused on how we can scale those clinical interventions to impact larger communities that aren't geographically bound within a 15-mile radius of our headquarters, for example. So that shift from understanding what worked for a community that's just all very geographically concentrated and dense to figuring out the strands of that are actually scalable and then replicating that across different communities across not only the state of California, but across the country kind of requires some baseline level of software. Like at some point, the physical process can work in a small, dense area, just start breaking down when you are trying to do things at scale. And so the journey kind of was starting as a software engineer, trying to figure out some of these operational processes, because without a process in place, you can't even automate the process because there is nothing to automate in the first place. It's all completely different, completely ad hoc, completely on a case-by-case basis. And so really part of the job was, can we even create the process first, which is an operational problem? And then once the process has been created and change managed through, we then build software that actually then tries to automate and smooth out the workflow. And so that's kind of how my software engineer job turned into an operational change management role at the beginning, because we had to start off building processes before you can even build technology for it. And once we started doing that, we started changing the culture of the organization to focus more on process, to focus more on things that scale. We started building software for that. And that's what kind of started some of the ability to rapidly grow the business. So for context, for example, we grew more just in the last year, for example, from 2023 to 2024 than we did from 1990 until 2019 over that 27 year time period. So it's really remarkable to see the type of growth that's enabled once you have processed the right technology partners and operational leaders in place. And we are still on that process today.
Every time I have one of these conversations, I feel like I'm learning something. And the reason why I was nodding and smiling was because our approach is all about going in and executing that process, oftentimes just in a very manual way, so that we can create standardized manual process that we can then automate. And I feel like all over healthcare, there are examples of just broken process. And that, in a way, is also why it's really hard maybe to digitize a lot of what's happening in healthcare, because that standardization isn't there. So your journey really resonates with, I would say, our philosophy on how we can effectively scale and automate. I mean, speaking on that point, your organization, like Astrana at that time, obviously it was ApolloMed, has grown rapidly. It sounds like it's the nice beginning of any good hockey stick growth curve that you guys have been going on that would make anyone proud. How has the operating model evolved, right? When you had this transition from the origin as a mom and pop shop, right, to using processes, using technology, and now really being able to scale a lot. What were some of the inflection points? And then as you're continuing to grow, where do you see future inflection points from an operational cadence perspective and operating model perspective?
Yeah, hockey stick growth, 27 years in, the path that every good startup takes, obviously.
It's a long neck of the hockey stick, you know?
If you zoom out long enough, yep. But joking aside, Paul Graham, I think, is very famous for recommending to startups that they should do things that don't scale. And in a way, I think probably, Frederik, it's very similar to what you just said, that we've all had to do things that don't scale, that are horribly manual. And I think part of the point of that is that when you're the one who does it and you can figure out the thing that solves the problem but then does scale, you have this incredible moat because you put in the work to kind of untangle that mess, to do something that's so sexy, that's so in the mud that no one else really wanted to touch, right? It's nowhere near as sexy as building a consumer app that just instantly scales and you can sign up 1 million people in one day or whatever it is. And all of a sudden you're good and you have hockey stick from day one. It's the hard work of figuring out the things that aren't scalable and trying to understand how each and every one of those can be problem solved or change managed or technology workflows built around it to enable it to scale one day that I think you and I probably both do on a day basis. So totally agree with what you're saying in terms of some of the inflection points. I mean, certainly leaving that close geographic proximity was one inflection point. I mean, it's kind of going from like 0 to 1, 1 to N, like having to figure out, yes, this worked. We put a lot of hacky things together. A lot of these things are manual and maybe that's just how we had to do things to make it work in the first place. But now that we have made it work and we need to do that again in Fresno and in San Francisco and in Sacramento and in Riverside and so on and so forth, that was really the first step in terms of figuring out, okay, we really need to sit down and like work all of this out or else it's never going to work. And it exposes the places where you're actually winning versus winning sustainably versus not, right? For example, things we were doing near headquarters in Los Angeles, we were winning because we had a certain level of density, because we had the ability to operate our own staff models, because we had the deep partnership with our local hospitals, we had a deep partnership with urgent care centers, all those things. When we started taking them to other places, even if we didn't know those were the reasons we were winning, if we didn't take them and it didn't work and things started to break, that's when we knew we were missing something because we clearly didn't lift and shift every single important part because it wasn't working. And so by having to do it going from 1 to 2, 2 to 3, 2 to 5, 5 to N, it forced us to kind of honest look at ourselves and figure out, okay, these are the things that actually matter because when we didn't take them, things started breaking. And these are the things that maybe didn't actually matter because even if we took them, didn't actually solve any problems. And it made us recalibrate what actually was important versus not important in the business. And that is something that we continue to learn even as we go through further inflection points like going to other states in California or going into other lines of business, other types of value-based arrangements, maybe in Medicaid or commercial that are maybe less typical or, less common in the industry today. So rambling a little here, but I'll give a short example of something that broke, as we moved outside of California.
Yeah, I think that would be great.
Because Medicaid in California is named Medi-Cal, as you know, Frederik, all of our system database tags are Medi-Cal. That is meaningless to someone outside of Medicaid. Same thing for the ACA exchange program, where in California, that's only covered California. We have everything tagged as, CC, for example, but as we move outside of California, that becomes a meaningful label. So even the little things around just nomenclature and figuring out what things should be named become something you have to take into account when you're scaling across different geographies, especially for an industry that is as corely aligned and integrated as healthcare.
Yeah, I was talking to another guest on our show who was employee number 7 at a medical group, and now she's COO with 2,000 employees. And for her, a big change was all of a sudden you don't know everyone in the organization anymore, and you have to communicate differently and you have to make decisions differently. Were there similar sort of evolutions from even your role? Obviously, you started with even a few hundred people. It's arguably hard to know every single one, but I think you've definitely surpassed a lot of those milestones as well for you.
Yeah, absolutely. I mean, I remember when I first started as a project manager, I was looking up some of my old files recently to use as a template for some of our new town hall meetings. And I found that there was a file in which I actually sat down for 30 minutes to talk to every single employee at the company when I first started. So just trying to learn. I had a file, for example, 30 claims examiners. I talked to every single one of them, tried to understand their problems, tried to figure out what the pain points in their day-to-day were. Every single credentialing person, every single clinical person. And that was possible to do, to your point, when there are 200 people at the org. It still took, a month or so, but possible to do. And that was also pre-COVID when everyone was in the same office. So it was easy to kind of go from door to door, walk from desk to desk, and really understand what people were doing. Today's day and age, for better or for worse, that's literally impossible. With 2,000 people across 30 different states or wherever people are, with a hybrid work and remote environment, literally impossible. So I think certainly just a ton of changes in terms of learning how to communicate differently, communicating more often, and just having things like town halls, which we never had prior to kind of my taking on a more leadership role at the company, getting people together in person when appropriate, maybe on a quarterly basis, just establishing a cadence that works for the organization at scale, even internally, not to mention how we manage providers and patient behavior at scale is certainly a huge part of that evolution.
That is interesting. Whenever you and anyone that has been in your guest seat prior goes through that, I'm always running through the list of things that we've trying to do and, certainly trying to follow all of your guys' footsteps. So I think that's very interesting also for the general listener. One thing about operations, obviously, specifically that I always love to understand is, does Astrana outsource? And full disclosure, Astrana is an investor and a customer of Third Way Health. But I think more importantly, what's your perspective on outsourcing as you have grown and as you're continuing to grow? How do you approach what you want to do in-house versus what you would rather have partners work with you on?
Yeah. So the question around outsourcing, I think we do it when appropriate, obviously, and when there is a certain level of trust and alignment we can build with a partner. I think outsourcing, just being very honest, typically I think for me, it has kind of a bad rep sometimes. It's because there are often times when the outsourced work or the outsourced vendor maybe has a lower standard for quality or has slightly different incentive structures than. So typically what we see is if there is a fee, for example, for doing a certain amount of work, the outsourced agency maybe doesn't have necessarily the same incentive to make sure the work is done perfectly, make sure that the agents are going above and beyond, to make sure that the outcomes for the business that is outsourcing the work are what the business actually expects when they outsource the work. That's not a problem unique to outsourcing, by the way, in my opinion. I mean, it's very possible that you have an in-house team that also doesn't feel very aligned, and they're also trying to just get the work done at the fastest speed possible and at the minimum headache possible to that. I certainly don't think that's an outsource-only problem, but it's one that probably rears its head more often when outsourcing if the structures aren't set up correctly. So I think similar to how we have to work with providers in a value-based contract and how payers work with us in a value-based contract, there needs to be the right alignment set up in the contract from the ground up to make sure that the outsourced person or client or vendor is acting in the best interest of both parties when they are doing their work. In many ways, I don't think we would, say it this way, but in many ways, we are also the outsourced vendor for our payer partners in some ways. I mean, we are partners at the end of the day, but in a way, they are saying, hey, we think you guys are better at delivering care and coordinating the care for our members. And so we are going to delegate that risk and some of the functions to you. And we entrust with you that you will do it as well, if not better than we would do it, or else the members will get upset with us, the health plan, and leave our plan the next year. And similarly, I think that, but they've set up structures, right? Value-based arrangements where we are completely aligned with them and they're guardrails appropriately set up so that we are making sure that we are treating their members, again, as well, if not better than that they are. So I think in a similar way, that's how we think about outsourcing. It's if we can find the right contract, the right structure, the right alignment with someone, we're happy to outsource, especially if it's to a company that can do the task better than we can do it. We certainly don't have any delusion that we're the best at doing everything under the sun. So the things that we are good at doing, we'll do ourselves. The things that someone else is better than us at doing, we will outsource, but make sure that vendor has the right alignment with us, with outsource partner.
It's so interesting, and I feel like there is a little bit a shift of thinking happening in the industry on that. What used to be, I'll sell you a bunch of FTEs to do work, doesn't always create that type of alignment, and we're certainly all for it. For any organizations that are working or looking to work with you, what makes a really good vendor partnership on that sense stand out, right? And what are some of the key ingredients that you're looking for as a buyer, and if you put your operator hat back on as an operator?
I think there are probably three things in mind. The alignment question is the first and foremost. Is this a company that is willing to align themselves with you, that is willing to construct a win with you rather than just a purely third-party relationship where you're not really aligned? So I think that's key, the willingness to do that, and then the ability to construct an arrangement that actually gets that to be done. So that's number one. I think number two is, in this day and age especially, showing value upfront or in the very, very near term. I think it's probably gone are the days that it's easy to sell promising a 5-year ROI or something or a 10-year ROI. It really has to be kind of more immediate in nature for an organization, for ourselves and to be for myself, but also things I've heard from other, CEOs and COOs in terms of just showing immediate value and having a path to showing value because of the revenue and cost pressures that the industry is going through at the moment. Then I think three, kind of more qualitative nature, but really the partner having a kind of a can-do, self-starting attitude, partner which is not just sticking to the literal words that are on the contract around the SOW or the MSA or whatever, but really understands that when the client wins, they're also going to win. They're going to have more business. The client's going to grow. They're going to have more fees, and really doing what it takes to make the experience a positive one for both sides. Not just saying, hey, this is strictly by the letter of the law, not part of the agreement, so I'm not going to do it, when that would actually lead to downstream problems with things that are actually in the contract. This is not an ad, but that's something I think you and your team do really well, really trying to understand our problems, working through change management, working directly, rolling up our sleeves and working with our teams in a way that isn't technically in the contract. We didn't say that you had to do those things, but you guys understand that doing those things is what's going to make the overall relationship work for the long term. And I think all of our most successful partners and vendors have that kind of attitude. I think that's probably the single most common thread. That and being able to show value and alignment are just critical if it's going to be a long-term successful relationship.
Thank you very much. And look, we've certainly enjoyed the partnership and for being off the cuff. I think those are three really good points. We try to ask everyone sort of some similar questions, so it's interesting to compare and contrast. But how do you describe what you're doing to others outside of the healthcare industry?
I really struggled with that question. I still kind of do. It really depends, I think, on terms of people's background with healthcare. But, the simplest answer is I wrangle problems in healthcare. I think that's what I say on my LinkedIn is I just wrangle problems in healthcare. Every day it's new problems. Feels like dodging, storm of problems or, trying to get to navigate big, slow moving ship through, a storm of problems. And I think that navigation is probably what makes me feel like we are building that moat because there are just so many problems day to day that there's no step function, magic bullet solution to any of it. It's not that someone could just come in and instantly fix all that is wrong with our healthcare system today. It's the process of working through each incremental issue where we are generating each incremental part of value. So I think that is the necessary grind it takes. Getting back to the question, that was more than 2 sentences, but getting back to the question, I think I would say I wrangle problems in healthcare. I'm trying to build a healthcare system that I would want to recommend to my friends, to my loved ones, to my family, that I'd be proud to use myself. And the way we're doing that is by building technology, infrastructure, services, and virtual and physical footprints that allow for you to get great healthcare when you need it at a cost that you can afford. And that normally springs up, a million questions about why don't we already have that? What does that mean? How are you going to do that? How do you beat the incumbents?
Yes,
but that's
it's
what I
a
try
tricky one. It's a healthcare thing. Yeah.
How do you describe your role in 2 sentences? Very curious.
That's a good question. I didn't prep for an answer to my own question, but I struggle with it similarly because I largely go back to our mission and try, which is all about improving healthcare access and experience for patients and getting patients and providers faster answers to their questions. But again, it's not a good cocktail party one-liner because then it's like, well, what does that mean?
Just more questions than answers, right?
It really is. I'm still struggling. So this is why I love this question in part because it helps me iterate on version 963 of what my one-liner is.
Just to make a quick plug, I think the reason I say something generic, like something I want to recommend to my friends and family, is because I think so few of us actually experience healthcare in a way that we would be happy to recommend to our friends and family. People just complain about it. They are never over the moon about it. Whereas in every other facet of my life, there are things I would recommend. Like I went to a new restaurant. It's great. I would tell my friends about it. I saw a new movie. I saw a new TV show. So it's just odd to me that there isn't a similar level of excitement around, healthcare is inherently not a fun thing to do, but there are other not fun things to do that you would still recommend as being the best of the worst of the bad experience, so to speak. So at least people resonate with that idea of not being able to recommend something wholeheartedly.
I couldn't agree more. One of the reasons why we started Third Way Health was because there is a dental practice in Brooklyn called Grand Street Dental. And it's an amazing space, great technology, super smart, well-educated people giving you assistance. There aren't very many healthcare experiences like that, right? And so it was like, wow, what if every experience could be like that? And then it turns out that we as Third Way Health have kind of realized that that is also a big problem to tackle. And so we're just starting with the front office for now, but it's so true that there's plenty of room for improvement in those experiences. What does your calendar look like? And I think where this goes is more, do you guys have an internal operating cadence that you follow? What does a day in the life look like for Bren and Sim?
Yeah, it's a great question. Here, I'll pull it up. Mondays are my kind of internal days, typically. So it's a lot of one-on-one meetings with my direct reports, got around 20 of them. So these are 15, 20, 25-minute sessions, depending. Not everyone goes every week, bi-weekly or tri-weekly. I get through all of them. And this is also kind of space for direct mentorship, especially for folks who are newer to the organization, having the opportunity to really spend more time with them, answer questions, help them build mental models around what the healthcare ecosystem looks like. I think is really important for me because there's just so many disparate pieces to connect without the right mental models and the ability to test those models, ask questions and see where the model fails, and then you have to build a new piece on top of it so that when you encounter a new situation, you can actually solve that problem. That's kind of what those sessions are for. I also use Mondays typically for interviewing people, although ironically today, I guess I'm the one being interviewed. But most of the time I'm interviewing key members of the team and serving as the final either interviewer or sell the company or the opportunity to the candidate. It's a big part of building the right team and having the right people come on board. I would say that typically I have 2 or 3 on average, it's kind of spiky, but 2 or 3 investor/analyst, sell-side analyst type meetings a week. This typically picks up probably like 10 or 15 post-earnings calls, and there are conferences to go to that spur a lot of this activity. And then on other weeks, I might have just 1 or maybe even 0, depending. That's a kind of an outward outward-facing role in terms of just describing the progress we're making sure that people understand the metrics that we're tracking and how we're tracking against them, and building confidence in the story and the business. Last week, look at last week's calendar, I had a town hall for the company. So that's a quarterly event. We have a leadership summit for 35 of our key leaders, market presidents, VPs, etc. So that happens on a quarterly basis. We also go over kind of some of the key goals that we're tracking towards for the year, for the quarter, key metrics that we're looking at to see how we're progressing against those goals during that time period. That's generally a whole day. So that was my Thursday last week. Sometimes I go to events. Last week I happened to be presenting an award, for example, to the Dean of the Dental School at the University of Nevada, Las Vegas at the American Awards Gala for Vegas. So that was a hard thing for me, just to continue supporting our local community here in Vegas in all ways possible. And then the rest of the time is really just either business development or internal problem solving. It's operational.
Wrangling problems.
Yeah, exactly.
And you mentioned this earlier. What do you look at? I know there's things that you communicate out to the public, but if you try to get a sense of the operational pulse of Astrana there, what do you look at, and how do you do that?
There are a bunch of kind of smaller metrics that we looked at. I think if I were to group them into categories, they revolve probably around access, quality, and those together kind of lead to the overall concept of like utilization and like care quality. And then on the other side, growth related metrics. I mean, at the end of the day, our business is pretty simple, right? We grow. That leads to kind of top line revenue growth if we grow membership, and or we take care of the members that we are entrusted with more effectively. That's kind of where your margin comes from, if any, right? So it's a pretty simple formula. You either grow more and or you take care of them better, and really the results financially should fall out from there pretty naturally. So in a way that's kind of lucky, because the operational metrics we track pretty directly correlate to kind of the financial metrics, which are tracked by financial investors. So on the access side, for example, maybe some key metrics are, percentage of annual wellness visits, percentage of annual physical exams, member without a visit percentage, depending, on the type of patient. We track lag times between a prior auth being issued or the PCP visit and when the date of service on the claim for the specialist visit end up taking place. So if that gets too far out of whack, if it's referred to an MRI or something or a cardiologist, and then you don't get the MRI until 6 months later, 3 months later, clearly we have a problem in terms of access. And we can track that by specialty, by region. So there's some cool dashboards we can use to make sure that access is generally good across all specialties. Patient satisfaction, of course, I think that's something you guys track as well. And that can take place in many, many different ways, whether it's like a CMS CAPS type survey, whether it's an NPS type survey, whether it's even something like Google reviews or Yelp reviews, all that kind of makes up the overall shape of the patient experience. And then at the other day, kind of preventive care, usage, and quality metrics and outcomes of those quality programs or disease management programs. So that's kind of on the utilization quality side of things. On growth, simple things like membership across each line of business, membership by region, type of risk arrangements that we're in per region, per membership, per payer partner. And I would say that those are the main ones. Then there are people-related metrics I like to look at, employees, hiring, attrition rates, things of that nature. We do a quarterly internal survey of all of our employees. We were proud to have gotten 500 of our 2,000 members, our teammates, responding just a couple days ago. So we track those scores, ask the same questions every quarter, track them on a quarterly basis, and try to improve how it is to work at Astrana. Those are probably the big categories. And then again, all of the revenue and EBITDA kind of metrics almost kind of fall out from there. The more members, the higher the risk, the more revenue. It's pretty simple. The better we do in terms of taking care of the patients, the higher the gross margin, and it all kind of falls out.
I think the metrics around patient access are super interesting, and it kind of speaks to the unique role that you have really to track the patient's longitudinal journey, right? Like this access to care one is fascinating, the lag time there. So
the cool thing is we can actually do something about it. Like if we see an issue, we can actually go contract a new provider. We can build a new clinic or something, right? Like they're actually pretty obvious actionable items you can do to fix that issue. And at the end of the day, it's about building a system that you'd be proud to refer your friend to or your mom to or your partners to.
Yeah, very interesting. If you give a piece of advice for other operators in healthcare, and I think you have this really interesting vantage point because you are sort of the helm of a lot of general value-based care activity and transformation. You have this operations background. You're very savvy with technology. What's one thing everyone should pay attention to in the next year?
It's a bit of a cliche answer, I think, but
Gen AI?
Not necessarily Gen AI, but just the role of technology, like AI in general.
Yeah.
AI, machine learning, whatever you want to call it. The reason I say that is because, to me at least, we're way overhyped, in terms of AI and its impact. We have been for some time. But amidst the hype, there is actually a lot of real value and a lot of real use cases. I guess I'm just scared that people will start, because of the over exuberance in a very short period of time, healthcare operators, especially given typical healthcare orientation, will write it off as all hype when the reality is maybe 99% of it is hype, but you still have to find the needle in the haystack that actually does add value, and the value that it will add faster than I think a lot of us will realize is going to be massive. It's going to be game changing in terms of what it can do for kind of the healthcare ecosystem. So I'm very much an AI optimist long term or even medium term. I think day to day, I probably poo-poo the hype and kind of sound maybe like a pessimist, but I think it's absolutely something we need to be parsing through in an intelligent way to see what we can use on a day-to-day basis to improve the patient experience and the provider experience. I think a couple of key areas, and people know this, I think, but administrative automation, claims, prior auth, eligibility, credentialing, grievances, all of those things will be with AI very, very shortly. I think patient engagement, patient experience, customer service can and should be with AI, or at least AI assisted very, very shortly in the near term. And even that can go a long way to improving the experience that people have with interacting with the healthcare system.
Yeah, it's so interesting. I mean, on a small level, I think I told you this, I used ChatGPT to review NDAs.
Yeah.
That was an isolated use case, and it was really good, like really good. And so I feel like specifically on the administrative side, there's a lot of boxed in use cases where there's real tangible value, and the other harder stuff is going to take a little bit longer. But I am an optimist as well.
For sure.
Last but certainly not least, what's your favorite healthcare statistic?
Oh, that is interesting. I don't know if I have a favorite statistic off the top of my head. I have a statistic, and it's probably, in fact, kind of a sad, kind of a not so great statistic. So I don't know if it's favorite, but maybe I'll just share it anyway, and you can choose whether to, use it or not.
Share it.
Average expense borne by the healthcare system per inpatient day, on average across the country, is over $3,000 a night. In California, it is even worse at over $4,000 a night. This is Kaiser Family Foundation. So I think that just underscores, if we really tried to think about sites of care and what is appropriate, and if we were to redesign the entire healthcare system from the ground up, from zero, and we did a resource allocation thought experiment around how many beds we should have in this country and where they should be and the types of acuity they should be for, I would be very curious what that ends up being in terms of what that total capacity should be given the modalities of care that people utilize today. Because I think we're in a very different environment now than we were 20 years ago, where outpatient facilities really weren't part of the healthcare system. Like a lot of people, if you think about healthcare, you think about a hospital. And I'm not saying that hospitals aren't important. They're a critical part of their healthcare ecosystem. My question is really around what are the appropriate places and how many beds really should there be? I think some places don't have enough beds and some places probably have too many beds. And resource imbalance is what causes a lot of the inefficiency, I think, that takes place today. So yeah, again, not such a fun statistic, but a statistic nonetheless.
A very profound statistic, and it would be an episode in and of itself to double click on that. But in the interest of time, wanted to honestly, if we do a part 2 at some point, I would love to do that because I could have gone on much longer. This was great. I really enjoyed it. Thank you for taking the time, for being such a great partner, and thank you for sharing a little bit about your perspective and your experience in operations. I thought there was a lot of really good nuggets for the healthcare operations and community at large. So thank you again.
Awesome. Thank you so much for having me. Appreciate your partnership. Maybe give it some time because I think people are tired of me, but would love to do this again sometime.
Sounds good.
All right. Thanks.